Good morning, everybody. Happy Monday. It's my honor to introduce Saeed Alsidawi. He's no stranger to any of us. I was going to list off his many credentials last night. He has said, can you just please introduce me as Saeed Alsidawi? We all know very well he's a good friend to MHI. Those of us who worked with him, everybody who's worked with him, loves, cares about, respects, and reveres Saeed. So it's a wonderful to have him back. He's discussing the assessment of aortic stenosis and atrial fibrillation. A warm welcome to our friend Saeed.
Thank you, Alex. Thanks for having me again. It's just a pleasure to be back here. I usually tell people, this is my favorite place in the country, in Minneapolis here, so it's always a pleasure to be back. And it's good to see familiar faces, some new faces as well. So Dr. Hurrell asked me to talk about this topic when I met him during a conference recently, and this is something I've been passionate about. I've done a lot of work on, so I'm going to share some of this with you here. Is how to assess the severity of aortic stenosis in patients who also have atrial fibrillation. So we're going to talk about how atrial fibrillation really complicates the assessment of aortic stenosis and the grading of aortic stenosis. I'm going to show you how we're really not doing a good job in that and how we're delaying the treatment for these patients. And I'm going to propose just a new approach of how we're going to assess these patients and how we're going to take care of them. So this is from one of the papers we published. This is a classic example we see on a regular basis in the echo lab. You have somebody with atrial fibrillation, some degree of aortic stenosis. You have variable signals depending on your RR interval. A lot of the signals will be less than the cutoff of severity, and then you get one single signal that exceeds the severity of, or what we call severe. So you see peak velocity 4.1, but when you average the velocities here, you get 3.5. So maybe I'm going to ask people who are here a question here. Based on what you're seeing here, what do you call this? Would you call this severe? Would you call it, this is not severe, the average is less than severe, or it depends? Who would say here this is severe? I have enough data to say this is severe. Not severe, or it depends? So what I'm going to try to show you over the next hour, that it really doesn't depend on anything. This is severe, and that's what I'm trying to the point we're going to try to change in the guidelines, hopefully over the next few years. So just a quick background here. Most people, the audience here, know this, but the way we define aortic stenosis is hemodynamically in the echo lab. This is what we've used for many years, and the way we define severe aortic stenosis is a peak velocity over 4. Mean gradient over 40, and a valve area less than 1. Now, most people who work in the echo lab know this usually doesn't work. It doesn't happen. Most of the time, you're going to get some discrepancy in these hemodynamics where the velocities and mean gradient will fall in the moderate range, but the valve area is severe. And then, this is the biggest challenge for people in the echo lab. Now, what do I do with this? Do I call this moderate, or do I call it severe? But remember, you can also define aortic valve stenosis anatomically using the aortic valve calcium score. This is going to become relevant more later in the talk, but just remember these numbers in the middle here. If you have a male with a calcium score of over 2,000 or a female over 1,200, this is based on European guideline 1,300 in the US. This is very likely severe aortic stenosis. The nice thing about aortic valve calcium score based on CT is flow independent. Okay, so you're not relying on your flow to show the hemodynamics. The other relevant information is, on average, when you follow patients by CT, every year that calcium score is going to increase by around 150 units. Okay, just remember these numbers again. They're going to become relevant as I show you more data later on. So calcium score is an important thing, and then it increases by around 150 units every year. Now, moving to atrial fibrillation, everybody knows this is common. The reason we see people in the hospital, this is the most common reason. That's the hospital service all atrial fibrillation a lot of time. It's more common as we get older. Same thing for valve disease. It's more common as we get older. So it's not uncommon to see these two conditions together in elderly population. Now, one affects the other though. So having aortic stenosis is going to make atrial fibrillation incidence more common. So in the general population, 1 to 2% atrial fibrillation. It's up to 9% in the moderate aortic stenosis population. And if you look at the TAVR registries and the French database, you're talking about around 30% atrial fibrillation at the time of transcatheter aortic valve replacement. And if you look at the low flow, low gradient AS population, atrial fibrillation is very common. It's up to 50%. I'll show you some data from us from Mayo. Now, when you have this combination, the outcome is always bad. And no matter how you look at this, whenever you have aortic stenosis and atrial fibrillation, your outcome is worse than having aortic stenosis alone. And this is after intervention. So if you look at the post hoc analysis from the TAVR registries, from partner trials, these patients do worse after intervention. And that applies to severe AS, asymptomatic severe AS, all comers with AS. Even if you look at mild and moderate AS, when they have atrial fibrillation, they all do worse, whether that's paroxysmal or persistent atrial fibrillation. And the question is, why is this? Why are these patients doing worse when we see them in follow-ups? Well, you might say, well, you have two conditions. Each one affect mortality, and the two conditions together, the mortality is going to be worse. Well, that's simple. Maybe that's one explanation to it. Maybe atrial fibrillation implies more advanced cardiac disease. That's going to carry higher mortality. But this is the one thing we're going to talk about more today is, are we just not doing a good job in these patients? Are we intervening too late on them? Are we contributing potentially to this worse outcome in these patients with atrial fibrillation? So in the echo lab, as you know, we're very dependent on mean gradient and peak velocity because these are things we directly measure as compared to valve area where you have to do a calculation to come up with that number. Now, atrial fibrillation patients, however, number one, they live in a low flow state. You lose that atrial kick. So it's going to take them a while, or sometimes they never reach this cutoff of severe aortic valve stenosis by mean gradient and peak velocity. So they live in a low flow state in general. And this is, like I said, this was shown in our Mayo Clinic database from MAC Elite, that if you look at the low flow, low gradient AS group, over 50% of these patients had atrial fibrillation. And same thing from the paradoxical low flow, low gradient AS. So these are patients with normal ejection fraction, but they have discrepant hemodynamics. Atrial fibrillation was very, very common in this population. So these patients, all in general, they live in a low flow state. And then on top of that, the guidelines tells us to average signals. So you see all these variable signals like I showed you in the first example. And the current echo guideline says take 5 signals, average them out, and report that. Where did this come from, though? So this is one example that this is what started most of the research we did. I was reading this specific echo when I was a fellow in Rochester with my mentor at that time, Dr. Nkomo, who did a lot of the work together. And we were looking at this specific echo. And I was asking him, like, how do I grade this? I don't know what to call this. I mean, I have signals that goes all the way to 5 meters per second. And I have signals that are not even aortic stenosis. So what do we do with this? I mean, do I call this severe? I mean, what do I do with this patient? Well, he said, the guidelines tells you to average, so let's average. I mean, I'm not sure this is the right thing. So he said, go prove it. And that's what we've been trying to do for the last 10 years, is to prove this is not the right thing to do. So this is what the guidelines tells us to do. And it tells us go average 5 signals and report the average mean gradient and the average peak velocity. Now, if you look at where did that come from, it really didn't come from anywhere. I mean, it's just people met and decided this is the way to do it. There is no data behind it, no science behind it. It's just the experts decided this way. So is there any basis for averaging? Well, I mean, if you really dig deep into the PubMed, you're going to find this one single paper that's from Harvard from 1970s. They showed that if you average 13 beats, and this is for cardiac output measurements, so these are LVOT VTIs, these are not aortic stenosis. You have to average around 13 beats to start getting consistent data, not necessarily accurate, but consistent data. So the guideline committee looked at this, they said, well, nobody's going to do 13, let's just do 5. And then let's extrapolate the data to aortic stenosis. But that's all you got. Okay, that's all the data about where averaging came from. I'm going to show a couple of cases that when we started looking at this project here, I went back into our database and started looking at some cases that looked like this. So this is just one example that a valve clinic patient, a 73-year-old gentleman, has aortic stenosis, persistent atrial fibrillation. They were referred to the valve clinic because of aortic stenosis. Again, they're in atrial fibrillation, a lot of variability, as you see, beat to beat variability. The valve looks heavily calcified, I mean, barely opens. And then you get different signals. You're going to get some signals that reach 40, this signal here, and then a lot of them, they don't reach 40. So the average ends up being less than 40. However, when you look at their valve area, it's 0.7. But again, like I mentioned, a lot of people ignore the valve area. They're just too focused on mean gradient and peak velocity. Stroke volume index is kind of borderline at 38. So how did we report this? Again, this is from Mayo Clinic Rochester lab. We reported this as moderate to severe. I just hate this classification personally. I encourage people not to call aortic stenosis moderate. It's just not helpful. Is it moderate or severe? I mean, the referring physician, what are they going to do with that information? I need to know, do I intervene or not? So moderate to severe should not be a classification for AS. But anyway, that's how it was reported because the mean gradient didn't reach 40, despite a valve area of 0.7. So this patient was referred for surgery from the valve clinic. The surgeon saw them. They said, well, let's wait 3 months, see if your mean gradient gets to 40. But unfortunately, this patient presented a month later with sudden cardiac death. Just another quick case, 68-year-old gentleman, also in the valve clinic. He's been symptomatic, significant dyspnea on exertion, exercise intolerance. Also has chronic AFib. His exam was consistent with severe AS. He had delayed pulses. He didn't have a second heart sound. Again, this is his echo. AFib, rate controlled. The valve looks heavily calcified, doesn't open. Always look at the valve when you look at the hemodynamics too. I mean, it should match to some degree. So this patient didn't even have a high signal. I mean, all his signals were, in the mid-20 range. Even if you use the highest signal, you're getting mid-20s. Valve area, again, 0.7. Stroke volume index, 31. How did we report this? We report it as moderate because the mean gradient was 25. So again, the reader of this report ignored the valve area, said this is just moderate. The mean gradient is too low for me to call it more than that. Now, luckily, the person was seen in the valve clinic. The person who saw them was suspecting severe AS based on the exam, and they got a calcium score which was severely elevated. And based on that, they were treated appropriately. So this examples here is to show you, are we really doing the right thing? Are we assessing these patients and grade them appropriately? So this took a lot of work. So this started 2016. This paper didn't come out till 2021. We had a heck of a time publishing this paper. Journals won't take it because, and for the main reason is you're going against the guidelines. Well, yes, that's the point. We're trying to show you that what the guidelines are showing has no science. So let's dig into the science behind it. So let me show you what we did with this. So we looked into our database and we took patients who had valve area less than 1. Okay, so by valve area, these patients were severe. And we said, based on that, let's see how these patients, how their flow pattern is, how their rhythm is, and how their gradients are. And then based on that, assess them and see. So this is kind of a breakdown of how these patients look. So a lot of the patients, 2/3 of them were in sinus rhythm and had a high gradient AS. So this was kind of our control group. As you see, the mean gradient of this group was in the 50s. Now, we had some atrial fibrillation patients that their average gradient was in the severe range. So as you see, it's 48, 12% of these. But our focus of this study was this group here. So the patients who were in atrial fibrillation, their valve area was less than 1, but they were not able to generate a gradient of 40 or a valve area of, a peak velocity of 4 based on average mean gradient. Again, we were averaging when we did this study. The average mean gradient of these patients were 29. Now, we used calcium score as our gold standard here to assess the aortic stenosis severity. So we went back to the echoes of those patients who were in atrial fibrillation. And so how many of them actually had a single signal, like I showed you on the first example, that actually exceeded the peak velocity of 4 or a mean gradient of 40? We found actually 1/3 of these patients had this. Okay, so 1/3 of the patients who were in low flow, low gradient AFib had a single signal that was ignored that exceeded 4 and 40. But what does this mean? So how did we do first? How did we grade these patients? Again, this is data again from Mayo Clinic Rochester lab, supposedly an elite echo lab. So how did we do in grading these patients? So it's no brainer. When they had high gradient AS, everybody called them severe AS. But once these patients were in low gradient, a lot of people didn't call them severe AS. They called them either moderate or moderate to severe. Even when they had that one single signal, people were more likely to pay attention to that signal. But in 50% of cases, we're still not calling them severe aortic stenosis. So the question is, how do they behave? So this is an important graph here. So this is how these patients look like. So again, using the sinus rhythm high gradient group as your control group, this is looking at median calcium score. The median calcium score of this group was around 2,500. So we know these patients were severe based on their gradient valve area. How do other groups compare to this? Now let's look at the atrial fibrillation high gradient group. So these patients were in atrial fibrillation, but they were also in severe AS based on gradient. Calcium score was significantly higher, okay? Despite a mean gradient that's slightly lower. Still in the severe range, but lower, which tells you, did we wait too long for these patients to get to the severe range? Now look at the low gradient AS group. This is the group that a lot of people were hesitant to call them severe based on the valve area. Their calcium score, median calcium score was very, very similar to sinus rhythm high gradient AS group. So these patients, by calcium score, they were severe, but we're not calling them severe. Okay. Now, what did we do with these patients? This is the rate of referral for treatment. We're around 3 years late in referring these patients for aortic valve intervention as compared to the high gradient groups. So we sat on these patients 2-3 years before we referred them. And what did that translate into? This is their outcome after aortic valve intervention, whether it's surgery or TAVR, they did worse. This is their 5-year outcome after intervention. Anybody who had AFib did worse. Okay? So we sat on them 2 more years, and they just did worse afterwards. So what we're trying to say based on this, that this patient is trying to show you they're severe, and you're ignoring it. So can I call severe AS just based on this one single signal? And the answer to this, based on what I just showed you, is yes. It's like you have a biopsy, right? So when you do biopsy on a tumor cell, you don't need every single biopsy to be positive. Only one of them is positive is enough to call this, this kind of cancer. Same thing with this. The patient here is showing you they're severe. We're averaging their signals and telling them, no, you're not severe, despite the calcium score that's similar, like I said, to the high gradient AS group. Now, some people would ask, well, how do you calculate the valve area? And I understand the mean gradient is started at peak velocity. Don't you still need to average signals in the LVOT to calculate your valve area? So that's what we did next, is you can calculate the valve area based on the average signal, but you can also take the highest LVOT VTI and the highest aortic valve VTI and take a ratio. And when we looked at this, there was a very strong correlation between the two. So the two methods gave you the same valve area. So what we're trying to say based on this paper, just ignore this whole averaging thing. Just take the highest signal in the aortic valve VTI and call the severity of AS based on that. Take the highest signal from the LVOT VTI and use that to calculate the valve area, and that's it. Now, again, we had a really hard time. This paper went around 12, 14 journals before Circ Imaging took it. And the reason they took it is because I was presenting this work actually at a conference, and the Circ Imaging editor-in-chief was attending that conference. He said, I'm interested in this work. Can you send it to me? Eventually, he took it. But it was criticized, people, again, appropriately and inappropriately, in my opinion. But this is the main reason why people criticize it, is these are two completely different group of patients. They're hard to compare. Baseline characteristics are very different. So we decided to look at this topic in a different way. Let's look at the same patient. Let's use the patient as their own control and see what happens to this patient when they flip rhythm. So a patient who has aortic stenosis in sinus rhythm goes into AFib or vice versa. What happens to their mean gradient or their velocities or valve area when they flip between rhythms with two echoes that are close to each other within 6 months? So we first started by publishing a case series on this. Just an example here to show you how this works. This is a 73-year-old female. She has non-aortic stenosis, and she came in atrial fibrillation. Valve looked heavily calcified, doesn't open. Stroke volume index was 31, so low. Again, 35 is what we use as a cutoff for low flow. If you use the average mean gradient in AFib was 37, but if you use the highest signal, it was 49. So this patient underwent the cardioversion, went back to sinus rhythm. Within a month afterwards, had another echo. As you see, the stroke volume index went from 31 to 47. Look at their mean gradient now, just a month later, 62. So even using the highest signal, we underestimated the severity on these patients, which tells you when we average how much we're underestimating this. So what we're saying here is, not only pay attention to the valve area, it's important, but even using the highest signal, you're also still underestimating, but you have a higher chance of grading this appropriately. That's why we're trying to say from this. And as you see, when they go back to sinus rhythm, their hemodynamics are completely different. Just another example, this is actually the opposite. This is a patient who has non-aortic stenosis. Their mean gradient is 34, valve area is 0.7, and their stroke volume is 51. A month later, they come to the ER in atrial fibrillation. Their stroke volume index now is 37. Their mean gradient is half of what it was, even based on the highest signal. The highest signal is only 17. Again, which tells you what atrial fibrillation does to the hemodynamics. You drop your mean gradient by half, even based on the highest signal. Again, tells you how much we underestimate when we average these signals. Another example here, just another patient, same thing, in atrial fibrillation, despite being well-rate controlled AFib and fairly regular rhythm here. I mean, although they're in AFib, they're not very irregular. Stroke volume index 32, valve area is 0.7. You cardiovert them, they go back to sinus. Stroke volume index is now up to 42. Their mean gradients goes up to 40, up from 24. Again, just 3 examples here to show you how much we're underestimating the severity of AS in these patients. This is a really nice case because it shows like in stages how things happen. So this is an older female. That's actually I saw in the valve clinic. She's 9. We didn't know much about her. She came to the emergency with shortness of breath and chest pain. Now, this is also the other problem. A lot of people blame the symptoms of these patients on atrial fibrillation. While you're short of breath, you have AFib. It's not the AS, it's the AFib. So this patient comes to the emergency in AFib. She was in rapid, in RVR. Her stroke volume index was 21. The valve looked really heavily calcified. Mean gradient was 17. Even if you use the highest velocity, it was 23. But her valve area is 0.7. So really tough hemodynamics here. I mean, do you call this severe, moderate to severe? Mean gradient is only 17. I mean, a lot of people won't call this severe. So we cardioverted the patient because I knew I was interested in this topic. I decided to get an echo the next day. So these echoes are only 2 days apart. So your atrial hemodynamics didn't even return. I mean, you don't have mechanical atrial contraction yet. You're in sinus rhythm based on EKG. But the atrium, there is no way it's contracting, it's still stunned. This is the very next day, your stroke volume index goes from 21 to 37, and mean gradient go up to 34, 2 days later. Again, which tells you in AFib, it's not only the atrial kick, it's the regularity of the rhythm. And we have good data from EP, from our EP folks about that. When you take AFib patients and you pace them, leave them in AFib, but pace them, their wedge comes down, their cardiac output improves, even before they go back to sinus rhythm. So this patient's mean gradient doubled just in 2 days. Now, we didn't do anything yet. I actually brought her back after a month when I knew her atrial contraction would come back, and I repeated her echocardiogram. Now her stroke volume index is up to 32. Now her true atrial kick came back. Now her mean gradient is 38. Valve area, notice that in all these echoes, the valve area doesn't change because your VTI, LVOT VTI goes down in AFib and the aortic valve VTI goes down, but the ratio doesn't. That's why valve area is very important to pay attention to in these patients. So, again, people don't like it. There is a LVOT diameter, all these things. Well, that's not the reason not to use it. Go back and look at the measurement and make sure they're appropriate. But you cannot ignore the valve area in these patients. Now, after we published this case series, we wanted to look into more patients who came this way. So this is one of our fellows put this project together. So we took 12 patients, same exact concept. These patients had 2 echoes in 2 different rhythms within 5 months as a median between these 2 echoes. So again, it's a proof of concept project. This is from American Society of Echo, Journal of American Society of Echo. And we wanted to just see what happens in general to your hemodynamics when you flip rhythms in a 12 patients. And as expected, your stroke volume index, once you flip into atrial fibrillation, goes down. Your flow rate goes down. Your peak velocity comes down, and mean gradient is lower. So again, just a proof of concept. This is using each patient as their own control. Hemodynamics are completely different. So this is something we just published a couple of months, in November of last year. So, what we decided to study in this paper is the TAVR population. TAVR population is a very nice population to study because you have all the data on them. You have to log in all this data, and you have a calcium score on all these patients. So it's an easy population to study. So what we did in this project is we looked at the time of TAVR, how do the hemodynamics and the calcium score different between sinus rhythm patients and atrial fibrillation. So a couple of interesting observations. At the time of the procedure, what we first noticed is that atrial fibrillation patients were 2 years older than sinus rhythm patients. Now, and that was an intriguing kind of observation. Why is that? I mean, are they just older because they're older, or are we really sitting on them 2 more years, right? I'll show you how we prove this point. We're sitting on them for 2 more years. That's the answer to this. I'll show you how we prove this point here. But this was the first observation. I mean, the AFib patients were 2 years older than the sinus rhythm patients. When we looked at the distribution of calcium score between AFib and sinus rhythm, the way we defined very high is anything over 3,000 as a calcium score. That's very high calcium score on the aortic valve. There were patients in atrial fibrillation, over half of them were the calcium score was over 3,000, which again tells you how long we're sitting on waiting on these patients and waiting for that mean gradient to be 40. It's never going to be 40. But eventually somebody decides to intervene on them, but we're sitting too long on them till their calcium score is significantly up. So this was the central figure for this paper, just to kind of quickly go over this because it summarizes all the findings. So 820 patients we had all the data on. So almost 2/3 were in sinus rhythm, 1/3 were in atrial fibrillation. So again, high percent of AFib in the TAVR population. As expected, the stroke volume index was higher in sinus rhythm than atrial fibrillation. Mean gradient was higher in sinus rhythm, 45 versus 42 in the, on average in the AFib. Again, the intriguing thing was the AFib patients were 2 years older. And now when we looked at the calcium score, this is very interesting because if you see even men or women, the calcium score was 300 points higher in AFib as compared to sinus rhythm. And remember what I showed you, the 2 years. So every year the calcium score is around 150 points higher. So this is essentially the 2 points. That's what accounts for these. So we're sitting 2 more years on those patients, and that's reflecting on a 300 points higher calcium score by the time we intervene on these patients. So this 2-year age difference is actually a 2-year delay in intervening on the AFib patients, essentially. They're not just older. Again, we're seeing, again, the same thing. This is the AFib, the blue line here is the AFib patient after intervention, they do worse. Okay. Now, we still here didn't answer the question, are they doing worse just because they're in AFib or are we waiting on them too long? And the answer to that is both, okay? So when we broke it down by rhythm and calcium score, in general, whenever you have AFib, you're gonna do worse, regardless of what your calcium score after aortic valve intervention. But if you wait longer, you do even worse. And we found this cutoff of 2,400. Once you get to 2,400 of calcium score, you're gonna do worse after intervening on the aortic valve because you waited too long, essentially. And we saw that in the sinus rhythm and the AFib population. But you're more likely to reach this number if you're in the AFib because we're just waiting for the mean gradient to be high. So this breaks it down again, sinus rhythm, AFib, and based on calcium score. So AFib is bad, and then intervening late on AFib is even worse. Last couple of slides here. So this is coming up, just got accepted also at European Society of European Heart Journal Cardiovascular Imaging. So I just showed you that we wait 2 years on these patients. So we took these AFib patients and we went back 2 years. How did their echo look 2 years earlier? How did their hemodynamics look 2 years earlier? What happened to their heart waiting on in these 2 years? So this is at the time of intervention. These are all the AFib population. This is at the time of intervention. This is 2 years prior. So by waiting 2 years, their EF was lower, their filling pressures were higher, so their systolic function was worse. Left atrial volume index was higher. And then we'll come back to these. Their stroke volume index was lower, and they had significantly more moderate or severe MR and TR. As you see, percent of patients who had moderate or severe MR went from 17 to 36%, and same thing for TR. So by waiting these 2 years, these patients sustained significant structural damage. Their EF is lower, their stroke volume index is lower, they're more MR and TR, and then their diastolic function is worse. So waiting these 2 years, there's more damage that happened. That's why these patients are doing worse. Now, what we're proposing here, with the journal didn't like, so we had to tone down the message is, so that, people are just not going to pay attention to the valve area. That's just a fact that we're not going to get over. So can we change the cutoff for severity of aortic stenosis in AFib patients? Can we just propose completely new cutoff based on mean gradient and peak velocity? And based on this paper, this is what we're proposing. Use 30 as mean gradient and 3.5 as peak velocity to call the aortic stenosis severe in the AFib population. Because when they were severe, because we knew 2 years earlier they were severe, right? I just showed you the data that by the time we intervene on them, we were 2 years behind. So when they hit the severe range, these were their hemodynamics. Their mean gradient was 30. Their peak velocity was 3.5. So can we use these cutoffs to call severe? Well, the journal said, tone this message. We like what you're proposing, but tone this message and show us in a bigger paper or bigger population. This is only 136 patients. So we just built a bigger database. We have 5,000 patients now. We're going to do the same project. But that's what we're going to propose. People are not going to pay attention to the valve area. Forget it. Let's change the cutoff for mean gradient and peak velocity and allow people to call severe at a lower cutoffs as compared to the sinus rhythm patients. So how do I go about this? So this is just an algorithm I put together. Again, it's debatable. You can change the order. You can change the way you're doing things. But that's how I assess these patients when I see them in the echo lab. If I'm reading an AS case and the patient is in atrial fibrillation at the time of their echo, if your sonographer took the time and averaged the signals, great. And if that average is over peak velocity over 4, a mean gradient over 40, this is severe. You're done with that. But let's say, the average signals didn't end up going there. Let's say the average signals were mean gradient less than 40 and peak velocity less than 4. Look at the valve area next. Okay, and again, don't ignore that. If you don't like the valve area, You have to educate the sonographers. You have to do the job to make sure the calculation was done accurately. You just can't ignore this something just because you don't like the way it's done. So go back and make sure the LVOT VTI was done appropriately. Do I have a good sample? Was it placed appropriately? Was the LVOT diameter measured appropriately? And if you do all of that and you're still getting these hemodynamics, go back to that echo. Was there a single, like I showed you, a third of these patients, you're going to find a signal that exceeded the cutoff for severe. And if you find that signal, just call it severe. You don't need anything else. Don't average, don't do anything. This is severe AS, like I showed you. Now, also I showed you that a lot of those patients, even if they don't reach that one signal that's over, a lot of them are still severe. And if you're still suspecting the patient is symptomatic, you don't know the source of their symptoms, use aortic valve calcium score. So if you're facing discrepant hemodynamics in AFib, you have to think this is severe and talk yourself out of it rather than the other way around. So you have to prove to yourself this is not severe, not to prove to yourself that it is severe. So say this is severe and try to prove otherwise, not the other way around. That case, you're going to miss less patients. So to summarize, hopefully I convinced you that by averaging, we're hurting patients. We're not assessing aortic stenosis appropriately. Whenever we average, we're underreporting. Even the highest signal underestimates the severity of aortic stenosis. By doing that, we're under-referring patients. We're late 2 years on those patients. And those patients are doing worse because we're doing that, because we're delaying their referral. They're getting intervened on 2 years later, and their mortality is higher. Whenever you're faced with low gradient AS in atrial fibrillation, think this could be severe. Again, go back, look for the highest signal, use aortic valve calcium score to assess the severity of AS. Use the highest signal whenever it's available. And like I said, aortic calcium score is a good measure to follow these patients. Now, what we're also looking into, can we follow patients based on their aortic calcium score, not just echo? And if you do, how often do you serially check this? We're not quite there yet, but that's just another thing that we're looking into. That's all I have. Happy to take questions. We're way ahead of time. It can take a lot of questions.
A great talk. I mean, I think that the way I see it, you picked one population out of the severe AS population and then you're describing a problem that we have had for decades, right? So even I don't know what Nishimura always says, the severe AS patient paper is what, based on 20 patients or something? I mean, so the guidelines are still carrying through from a very small population, right? So what we take as severe AS, you're right, maybe everybody with 3.5 or a mean gradient of 38 is actually severe, right? So now you're taking that from the aortic stenosis. So I was just wondering, with your big data set, is it maybe even worth exploring that again instead of just the AFib population, which is, I think in some papers, I mean, you're saying 30%, but then it was 13% at some point, right? So I mean, it's a lower population overall. Do we need to reconsider all of that a little bit,
Yeah, I mean, with better technologies we have, do we need to intervene sooner on patients? And we know from Blaise-Carvello data is, a valve area of 1 doesn't correlate with a mean gradient of 40 and a peak velocity of 4. That's not the case. A valve area of 0.8 is what correlates with these hemodynamics. We know a valve area less than 1 it correlates with bad outcome. So again, waiting for that 40 and 4, maybe we're waiting too long. You're right, even in the sinus rhythm patients. So, I mean, that would be another thing to look into, absolutely. I mean, now that we have TAVR, I mean, that we don't have to deal with the surgical mortality, should we look into lower cutoff in general, not just in AFib population, to intervene on aortic stenosis patients? Absolutely.
Thanks for challenging us with an hour less sleep. That was a great talk. I'm wondering, I was intrigued by your study of the patients before and after AFib and sinus rhythm versus AFib. Did you look at the dimensionless index and how consistent it was in between those two?
So it doesn't change much. So it's like the valve area, it didn't change much. So it's interesting, when you switch rhythm, because both VTI, aortic valve and LVOT VTI change. So the valve area remains relatively similar between the studies. But again, what we were facing is people don't look at that. They're just not convinced the valve area is a measure that.
How about in patients with AFib with variable rates, how consistent is the dimensionless index in that situation?
So it depends on what you use. So I mean, for you to use that, you have to use the highest LVOT VTI signal. So you cannot just average the LVOT VTI and use the highest signal in
You have to do it beat by beat.
You have to, exactly. So in that case, you have to use your highest LVOT VTI and the highest aortic valve VTI. So when we looked at that correlation, they correlated very well. If you average and average, or use highest and highest signal, the correlation was excellent. So you can use that as a dimensionless index or aortic valve area calculation. So that's why we're trying to kind of make it easier and not average at all. Just use whatever is the highest signal in each tracing, and then just take the average, just the ratio of these.
Patients with paroxysmal AFib, what do you think kind of the burden is of, episodes of AFib before this starts to impact their dynamics?
Yeah, so that's a good question. So was there different in the outcome? There was some difference in the outcome, by the way. I didn't show that between patients who are paroxysmal atrial fibrillation versus persistent atrial fibrillation. Patient with persistent did worse after TAVR. Now, this data is based on patients when they were having their echocardiogram, were they in AFib or not? Okay, whether they were paroxysmal or persistent. So the patient had to be in AFib to be in the AFib group in this study, because we want to assess what they're doing during their echocardiogram. But again, some of these patients were persistent, some of them were paroxysmal. Now, like I showed, the percent of patients who have atrial fibrillation, paroxysmal atrial fibrillation is quite high in the aortic stenosis group. Even in the moderate stenosis, 10% of them have atrial fibrillation. So it's quite a common problem. We're going to face it all the time. The problem becomes if they have paroxysmal AFib and they're in sinus rhythm at their echocardiogram, would their hemodynamic be different than patients who are consistently in sinus rhythm? We don't know the answer to that. So that's another thing we're going to be looking at. Is if somebody has known documented paroxysmal atrial fibrillation, say they had an ablation, they're not in AFib now, but at the time of their echo they were in sinus rhythm. How does that affect your hemodynamics? Would their stroke volume index would be similar to patients who are in sinus rhythm all the time? They never had a history of AFib. So we don't have an answer to that quite yet. For this, they have to be in AFib at the time of the echo for all of this to apply, what I talked about.
An excellent talk. So I am a big proponent of taking the biggest, the highest Doppler velocity mean gradient. I never averaged. It kind of, to me, the analogy would be in low flow, low gradient severe AS where you have low EF. You put them on dobutamine to increase flow and try to differentiate whether it is 2AS versus low flow state. So to me, that AFib signal that you showed, I have few patients, I should say, the patient that you showed as an example of, that has a signal that is the highest, and that should be the way to do it. But you had the data to back it up. That is one. But my question to you is, if the valve area is not ignored, could we have diagnosed this severe, AS patients in AFib 2 years earlier?
Yeah, so that's what we're trying to say. If you don't ignore the valve, if you look at the valve area and you trust the valve area, you can call these severe. Now the problem is, are they also? They're also in a low flow state. Just remember that. So they also could be behaving as a pseudo severe AS. Some of these patients are not severe. Not every single one of them is severe. So because they lost their atrial kick, could they be in a pseudo severe AS? The valve is not opening because of their low flow state. So that's going to be the challenge. And I think you should suspect that it could be severe. And like I just said, try to talk yourself out of that rather than prove it. So you should say this is likely severe, and then try to go prove it. So my next step usually is to do a calcium score on those patients. So yes, you're right. Pay attention to the valve area. But I don't know if you don't have a single signal that exceeds 40 M4, if you can very confidently call every single patient like this severe. I think you still have to investigate them more. But I don't think you can clearly call it severe on every single one of them. Again, some of these patients didn't end up being severe. The ones that did not have high signals. The other 2/3 that didn't have high signals. Some of them, the calcium score came back low. Now again, we're using a gold standard here that's not perfect too, right? Calcium score is not perfect. It's flow independent, but we know from the initial data that sensitivity and specificity is not 100%. Somewhere in the 80-85%. It's not perfect. But at least it's a flow independent measure that we're trying to kind of normalize to here. But yeah, I think if you follow that approach and you trust the valve area and say this is likely severe, at least you have a higher chance of treating these patients on time rather than delaying for 2 years. At least, even in my echo report, sometimes I say, please consider doing a calcium score or something to investigate this patient further, so the referring physician knows what to do next, potentially. Especially if the referring physician is not a cardiologist or not as familiar with this topic.
Dr. Alsidawi, thank you so much for your time this morning. We have two questions thus far that came through via the webinar, the first of which comes from Dr. David Lin. He says, excellent talk, and his question is, how do you reconcile the data in patients with mean gradient of 15, valve area less than 1, with or without AFib? And he goes on to say this is not an uncommon situation.
So, I mean, what the mean gradient is makes a difference. I mean, you know, the way you're going to think about the hemodynamic. I mean, a mean gradient of 15, I'm going to be less likely concerned about severe. I mean, I showed you an example where 17 ended up being severe. It can happen, but, you know, unless you get the mean gradient to the mid-20s, especially if you're in sinus rhythm. One group I didn't show you here, that was the sinus rhythm low gradient AS group. A lot of those patients were not severe. Okay? Some patients were in normal flow low gradient, which is a completely separate category that we're looking at now. I mean, we have actually just published something on them. A lot of those patients were moderate, were not severe. So unless the mean gradient is in the mid-20s to low 30s and sinus rhythm, it's unlikely these patients are going to be severe. So if you're kind of 10 to 15 mean gradient, you should suspect these patients are less likely to be severe. Now, in that case, I would go back again and look. Did we really get good alignment to get the Doppler signal? Did we get a good valve area calculation? So go back and look at your calculation, because it's very unusual to have a mean gradient of 10-15 with a valve area of 0.7. Something is not right. Something in the measurement is not correct. Either the alignment is not correct, the calculation is not correct, but if truly that's what it is, it's, you know, you have to suspect this patient is less likely to be severe as compared to a patient who's 25, 30 and have a valve area of 0.7. That's a little bit different.
Thank you very much for that. So the last question via the webinar comes from Dr. Steve Bradley. I believe this is a similar question to what Dr. Sharkey was asking with the dimensionless index. However, the question is, this seems a version of low flow, low gradient aortic stenosis. Any role for greater emphasis on dimensionless index rather than adjusting velocity and gradient to be consistent across types of low flow, low gradient?
Yeah, I mean, like I said, it's the same thing. I mean, you know, whether you use the valve area or you use dimensionless index because you want to ignore the LVOT diameter, because a lot of people find it challenging. I mean, that's essentially the difference between the two. You're just taking one thing out of the equation to make it more consistent. Same thing. I mean, you know, if the dimensionless index fall in the severe range or the valve area fall in the severe range, just think that this might be severe. And we're talking about the atrial fibrillation population. So yes. However, remember, so dimensionless index kind of falls apart at the extreme of LVOT diameter. So if you look at the data behind dimensionless index, if your LVOT diameter is less than 2 or over 2.5, the correlation between that and the severity of AS falls apart a little bit. Valve area becomes a better measure for severity of AS. So also kind of, you know, you have to take that into account. That's one of the reasons why kind of the dimensionless index didn't come completely pick up as a parameter, because it's not consistent. It's not always consistent. So you have these, you know, 9-year-old female who's going to have an LVOT diameter of 1.8 or something like that. The dimensionless index is not very accurate on those patients, and this was shown consistently. Or bicuspid aortic valve patients who have an LVOT diameter of 2.8. They have a part of their aortopathy, the LVOT is involved. They have 2.8, 2.9 LVOT diameter. Also, dimensionless index doesn't apply very well. So in these extremes, avoid the dimensionless index. But outside of that, yeah, I mean, again, if you don't want to use the LVOT diameter, you can use the dimensionless index as far, again, you're paying attention to that number and using it in the grading.
Thank you. So we actually had one final question come in via the webinars from Dr. Edwin Zashiri. And he asked, does global longitudinal strain help in deciding if AS is severe and should be treated when gradients are discordant from the clinical findings?
Yeah. So, I mean, you know, there are a lot of other measures you can look at. You know, strain is one of them. Again, remember, though, in AFib, it's not easy to do strain. You know, that by itself can, you know, affect the strain measurement. So it's not going to be very easy to kind of get a good strain and track it down with this population. But yeah, I mean, you can always look at other measures. Strain is one of them. You can look at cardiac MRI. Joao, you know, talk a lot about, you know, the degree of fibrosis in the ventricle, and that measure had to intervene early on these patients. So there are other measures, and, you know, NT-proBNP levels, again, can be tricky because it can be high because of the AFib or the AS. So you can add all these components, but, you know, at the end of the day, what we're trying to talk about here is we need to grade appropriately before we go through that route. Because if you call this moderate, it doesn't matter, nobody's going to look at the other parameters. This is the thing. So if you call it severe, now people's going to start paying attention and try to apply the other parameters. So it starts by the echo report, getting the echo report correct. And then you can look at all the other parameters afterwards.
Thank you.
Did you have enough patients with and without surgery to compare survival?
Unfortunately not. I mean, this is going to be the challenge is, in a retrospective way, you will never be able to prove that this is the right treatment. We face the same issue. So one of the things we just published on is the normal flow low gradient AS group. So a good % of these patients were in sinus rhythm, normal flow, but low gradient. And nobody knows what to do with these. These are very challenging population. Their stroke volume index say 45, but their mean gradient is 30. And the valve area is 0.9. And what do I do with this patient? I mean, they don't fit in any group. So we found that a lot of those patients actually were more on the moderate side based on their calcium score. But do you treat them or not? I don't know, because I don't have a control group here. All these patients got TAVR, or all of these patients got surgery. I think it's going to take a prospective study to answer this question. It's going to be hard to answer from a database.
Hey, nice to see you. Great talk. It seems that we have a lot of non-invasive data. That's very good. And is there any role in your practice or for invasive hemodynamics? It seems to me that when I don't believe something severe, I just take them to the cath lab and just say, see, look, it's not severe, but I might be totally wrong.
I think that's a great question. What we found in a lot of those patients, when we took them to the cath lab, we got the same exact hemodynamics from them. I think a well-done echocardiogram, you're going to get matching data in the cath lab. I think when the invasive hemodynamics are helpful is when I feel I'm not getting good data from the echo. So let's say I'm not getting good alignment. I'm not trusting the measurements very well. But by my exam, this sounds severe, but I'm not getting the numbers on the echo. I think that's where the invasive hemodynamics would be helpful. But I think if the echo is well done and the hemodynamics on the echo, although discrepant, but makes sense because that study was done now. What I found when I told these patients, take these patients to the echo lab, I end up with exact same numbers, same valve area, same mean gradient, same everything. So, I think it depends on the quality of the echo. If the quality of the echo is good, and the sonographer did a good job, and you go back and review the data, and it looks fine. I just don't see doing an invasive study adding much. A lot of those patients, it just didn't add much. But when you feel you're not getting the good alignments, and the exam is discrepant from the other data, of course, I mean, there's still definitely a role for it.
Saeed, thank you for a great talk. What do you think distinguishes the patients with atrial fibrillation who have a high gradient versus those that have a low gradient?
Yeah, so I mean, there seems to be two different pathways that these patients take. Some of them still able to generate high gradient. Now, it takes them much longer, even the ones who generate a high gradient, it takes them much longer to generate that high gradient. So even when you take high gradient AFib and high gradient AS and compare them for the exact same mean gradient, the calcium score is much higher in patients who have atrial fibrillation. There seems to be two different pathways. One, patients have a ventricle that's not able to generate that flow across the aortic valve, and another population is able to do it. Now we're trying to do a cardiac MRI on these patients to try to understand, is there something different on them? Do they have more fibrosis in the left atrium? Do they have more LV fibrosis? Why are they behaving differently? Why some patients will never reach 40, despite having a normal ejection fraction, while other patients are able to generate that for you? Could be the MR and TR. I mean, that's what we're seeing for sure. I mean, a lot of the AFib patients have a lot of MR and TR. Now you have more backward flow. These patients are very hard for them to get to the 40 millimeter mercury. So other disease processes involved usually. Could be related to the AFib, could be not related to the AFib. Another, myocardial process. Again, fibrosis, they had an MI in the past, they have cardiomyopathy process separate from the AFib. Or the AFib was related to another cardiomyopathic process. So I think you have multiple hits to the ventricle that's not able to generate that high gradient. But we don't have an MRI data yet on them to be able to answer that.
Do they simply have smaller ventricles?
They could be, yes. And yeah, absolutely. And that's why they're not able to generate that. More diastolic dysfunction potentially. Some of those patients have amyloid, which is something we didn't look at in this study. I mean, amyloid is very common in this population, the AS population, as 16%, 17%. If you have AFib, it's probably even higher in the AFib population. Another thing that we don't have enough data on as well.
Yes, thank you so much for your time. We did have one more question come through the webinar from Dr. Sajati. And the question is, what is the correlation with degree of moderate MR or severe MR?
Yeah, so like I just showed, like a lot of those patients, by the time they get for TAVR, the AFib patients, around 35% of them had at least moderate mitral valve regurgitation. Part of it is waiting on them too long. Part of it just the AFib itself, just the remodeling and all these things. But 2 years earlier, when we looked at them, half of that percent had MR, around 17%. So waiting too long, there's the AFib process going on, there's the AS going on, more structural damage, and then more mitral valve regurgitation. So yes, I mean, and then again, remember, the more MR you have, you're going to be more likely to be in a low flow state. So it's again, more likely to have more discrepant hemodynamics. So it's more kind of a circle. I mean, just spiraling down from one disease to another, and then keep underestimating. Eventually, somebody says, it's time to intervene, and they just don't do as well afterwards because it's too late.
Maybe just a quick last one. So if you see these patients, right, it feels always like, to me as an interventionist, right? So everybody wants me to do the TAVR, right? It doesn't matter what, just do it, so then we're done. But nobody takes care of the rest, right? I mean, I'd say nobody, but I mean 13% or whatever, right? So the AFib starts in a 90-year-old, we don't care, but the TAVR needs to get done, right? I mean, so the question also is, maybe we have to rethink all of that a little bit, right? So if we're thinking about being very aggressive between 85 and 95, I don't know if EP is here today, but do we need to also say, okay, well, AFib starts, it's too old, we'll never get it done. I mean, do we have to be a little bit more aggressive with that then too, because they die earlier, right?
Absolutely. I mean, with a rhythm control strategy, potentially. I mean, it's a new diagnosis of atrial fibrillation in this patient. I agree. And probably the best thing to do here is probably get them back to the sinus rhythm before you even intervene on the valve and reassess their hemodynamics. I mean, that's by itself is as if you did a stress test on them and reveal their actual hemodynamics within a month later. The problem is a lot of those patients, by the time they come to you, they've been in AFib for like years, and there's really nothing you can do for them. I mean, it's a done deal. But I totally agree with you. I mean, I think if we're aggressive enough to do TAVR in a 9-year-old, we should probably follow the same strategy for the AFib. Because I showed you patients who stay in AFib, they do worse afterwards. Same thing when you guys do the MR-TR clips now. I mean, for those patients being in AFib because they were left in AFib since they were 50 years old, and nobody decided to do cardioversion. Now we're finding out. We always said, rhythm rate control strategy, it's all the same. It's probably not the same. 10 years later, it's not the same. Now maybe in the first 2 years it's the same. But 10 years later, when you have severe MR and severe TR, you have no solution to. Probably should have been more aggressive with the rhythm treatment early on and prevented this from getting there. I totally agree. I think we need to be more aggressive with AFib treatment early on and follow more rhythm control strategy early on.
It's just easier to do a TAVR than to keep a 90-year-old in sinus. I mean, come on.
That's great, to be honest.
I mean, your success rate with one is 99%, and your success rate with sinus is...
But the outcome is still worse.
Anything else?
Have you looked at BNP levels in the population?
It was very hard to interpret because, like I said, AFib by itself increases the levels, and then you have AS on top of it. So, I mean, it was very variable. I mean, it really had no pattern whatsoever. So it was completely useless.
Did you look at calcium score in women? It tends to be lower.
Yeah, so one of the graphs, let me see.
I'm sorry.
So this actually graph breaks down men and women by the time they get to TAVR, whether they're in sinus rhythm at the top and AFib at the bottom. So as you see, males, when they come to TAVR in sinus rhythm, 2,500, females around 1,600. In AFib, both of them were 300 point higher. So males were 2,800 and females were 1,900. So essentially a 2-year delay in both males and females based on the calcium score. Yeah, this is broken down. But this is important, yes. I mean, whenever you do a calcium score study on those patients, it has to be broken down by males or females. It's completely different cutoff.
What is your cut for females and severe?
So in the US, 1,300.
1,300, yeah.
Males, 2,000. European guidelines, a little bit, 1,200 is what it is.
The Europeans.
All right, well, thanks again for having me.